during the presentation as Dr. Levitt is talking, and then we'll have a question and answer session at the end of the presentation. So you will get your chance to answer questions. If you do have any, or ask questions, if you do have any questions, please put it in the chat box. And if you don't know where the chat is, if you're on your PC, your laptop, or your desktop, look at the bottom of your screen. There should be 3 little icons. One should say participants, one should say chat, and then there's another that says reaction. So click on the chat, and the little chat box should pop up on the right-hand side. You can chat it to me. Please don't chat to Dr. Levitt. Please don't chat to Kelly. They will not pay attention to that right now. I will be the one who will be looking at the chat. Kelly will try to look at the chat as well, but try to chat it mostly to me, your questions, and I will, Kelly or myself will present the questions to Dr. Levitt, okay? Please keep in mind that Dr. Levitt is here to talk in general about, hydrocephalus and shunts and, management. She's not your practicing physician, so please don't ask medical questions. She's not here to provide any medical advice, but general education. She can't speak specifically to anyone's case because she, except for Kelly. But keep that in mind. Keep your questions very general. We do have some questions that have already been submitted, which I will also present to Dr. Levitt as well. And now I am going to turn it over to Kelly so she can moderate and introduce Dr. Levitt.
Nope, you're good. You're good. Thank you, Lakeisha. Okay, I want to introduce this lady to you. She has been in practice. This is Jodie Levitt. She has been in practice since 1996 as a general neurosurgeon, and that means she does brain, spine, as well as peripheral nerves. There we go. She's had the pleasure of being in Utah. It's nice here. You guys should come visit. Since 2002, and opened her own private practice in 2007, located in Sugar House, which is a suburb of Salt Lake City. In her residence training, her chairman was a pediatric neurosurgeon. This allowed her to become extremely comfortable with shunts, and during that training, she was one of the first sites in the US working with testing for the first programmable shunt. She no longer works with the younger pediatric group as they are seen at Primary Children's Hospital in Salt Lake, but she sees patients of all ages, including infants and children, for opinions. She has also seen many difficult shunt patients, I'll claim that one too, over the years, and has helped many. She's looking forward to sharing with us her knowledge that she has acquired over the years. It is vast. She's a smart lady. She loves to teach and hopes we will all benefit from her knowledge and experience. Now, on a more personal note, Jodie, Dr. Levitt, is one of those neurosurgeons who comes into the pre-op area and braids girls' hair away from where she's going to do an incision, so she doesn't necessarily have to shave as much hair. Who does that? And I remember after one of mine, she's like, I'm so sorry, I had to shave this little teeny piece. I'm like, oh my goodness, this side of my head was shaved from previous surgeries. I'm like, it's fine. So she's just awesome. And I'm excited for you to hear from her. Take it away.
Thank you, everyone. I am floored at how many people are online, and I would like to thank Kelly and Lakeisha and also COVID, because otherwise we wouldn't be here together more than likely. And I put together something that I've already shared with Kelly. She changed my font, but something that everybody can understand, to include all the different kinds of hydrocephalus. And I hope that I can make sense out of it for all of you.
Okay.
Okay, so
take it away.
I go from here, or do I go share first?
Share screen.
Share screen here.
Yep, yep.
There we go. And I need to
go to presentation mode.
Right, which is behind this.
Yeah, okay,
there we go. This is why I need her. I'm a good neurosurgeon, but for this stuff,
She always apologizes. I'm sorry, I don't know how to do this. Or one visit, I came in with my husband and she's like, Glenn, make this work with my watch. Here's my phone and my watch. And then she's like, I'm so sorry, I don't know the technology. I'm like, we don't care. You know the important stuff more than this. So, okay. Sorry.
Well, I want to welcome everyone. And to start, one of the things that I found out probably about 5-6 years ago was there was a ribbon for hydrocephalus, and it actually has significance. If you look at it on the left-hand corner, you can see there's a drop of water that represents water in the brain, and there's two colors. Most of the ribbons have one color, and that's because dark blue is for adults and light blue are for kids. For all of you who didn't know that.
I didn't.
So,
You could minimize that so you can see your whole thing.
oops, right there?
Yep.
Okay. So, stop laughing at me. So what actually does hydrocephalus mean? Hydro means water, cephalus is brain. So basically it means water on the brain. But there are a bunch of different kinds, and I'm going to talk to you about the different types of hydrocephalus. But before that, I want to go through the mechanism of the brain fluid system so everyone understands the different kinds of hydrocephalus. All right. So when you look at this picture and you look at the brain, the left side of the brain is the frontal lobes. The back is called occipital. And the blue stuff that you see there are the ventricles. These are really important because in the ventricles, there's that red stuff called choroid plexus. Choroid plexus is what forms cerebrospinal fluid. It's formed in all 4 ventricles, and actually it goes from the top down through the middle, down through the bottom, and I'm going to show you what the flow looks like. Well, before I do that, let me just say, it's continuously formed, and Kelly said, somebody once told me it was like a shot glass a day, and I said, that's true.
An hour.
I mean, a shot glass an hour, thank you. And I said, that's perfect for somebody who doesn't drink. It's continuously formed and continuously reabsorbed. The reabsorption, and I'm going to go down one for a second. If you look up here, these are called Patchoni granulations. There's no test on how to pronounce that. But basically, the fluid circulates from the lateral into the third, into the fourth, and then it goes out a couple of holes. There's number 2 over there. And then it goes down around the spinal cord, and the sac is the same sac in the brain and the spinal cord. That's why when people do spinal taps, they do them way down low. And then it comes back up, and you actually, on some of the, one kind of MRI, you can actually see the pulsations of the direction of spinal fluid. Comes back up to the top and gets reabsorbed into that big blue thing there, which is a vein. It's kind of triangular shaped, you can't tell on this picture. It's called the sagittal sinus. And then it goes back into the blood system. So it acts, spinal fluid acts as a few things. One, it's a buffer so that if you hit your head or you hit your spine, you have a buffer in there so you don't damage it. It also cleans out the metabolic products from the brain. The brain are a bunch of cells. They're going to produce bad things that need to get flushed out. So the spinal fluid, that's another one of its functions. And I have to go back up here, I think. One of the things that recently has been proposed, I spoke to a pediatric neurosurgeon friend of mine who said that this guy back in the early 2000s proposed that some of the reabsorption were through the lymphatics at the base of the nose. He was doing studies in goats. And up until that time, nobody even thought that you had reabsorption anywhere else but at the top of the skull. At the beginning, he was deemed crazy as anybody with a new idea, but it appears with some of the newer studies that this actually is true. And there is also part of the spinal fluid that gets reabsorbed along the spinal canal. Now, there's no lymphatics in the brain or the spinal cord. So it has to be in the covering or outside of the covering. One of the things that people always ask are, okay, well, what's a normal pressure? And Kelly was talking before and she said, you know, somebody told me their pressure was 3 and my pressure was 160. I don't understand that. Well, pressure in the brain is measured in either centimeters or millimeters of water. Anybody who's ever had a spinal tap will know that there's this big manometer, which is just a tube. And you can watch the spinal fluid flow up the tube, and they're marked by centimeters and millimeters. And you can get an idea of the pressure by lying the patient flat. Because if you think about it, if you're standing up, what happens? All the fluid goes down, so the pressure is going to be higher on the bottom than it is on the top. So you have to do it with patients lying down and relaxed, because as soon as you cough or you hold your stomach tight or you breathe fast, the pressure that you're going to get goes up. The other way, one of the other ways, is to put a catheter in through the skull into the lateral ventricle. And I wrote here right ventricle. Well, most people are left brain dominant. So we want to go to the non-dominant side of the brain. You access it with a catheter, and then you can hook it up to a system that tells you what the pressures are. So it would be, a normal pressure would be 0 to 18 centimeters of water or 0 to 180 millimeters of water. Hence the difference in the numbers when people are talking. And the younger you are, the lower the opening pressure tends to be, unless you have something abnormal.
Like hydrocephalus.
Like hydrocephalus or meningitis. So our brains are inside a box that's hard most of the time, except in neonates and very young babies. So they can't expand. And what happens is, if you continuously make fluid and you don't reabsorb it, then the pressure inside the brain gets higher and higher. Now, in kids, they have soft spots, and so their heads start to get larger and larger and larger. And before shunting, and I'm going to show you a picture in a little bit, and you may have seen it on TV on some of the National Geographic programs, these kids with heads that are huge. Well, what happens is that pressure pushes and pushes and pushes and makes the head very large. But if you don't have the ability or the space, then what happens, you start to get headaches, high pressure headaches, irritability. You can get pressure that causes problems on cranial nerve. Cranial nerve 6, which causes the eye to look out, is very common just because of its location. Swallowing difficulties, visual loss from pressure on the eye nerves. And then, as everybody probably knows, learning disabilities, walking problems, balance problems, and in very severe cases, the real bad stuff. So we're going to talk about the different kinds of hydrocephalus. Number one is obstructive. Obstructive, just like something's blocked. So what can block the fluid system? Well, it can be blood. It can be a tumor like the picture on the left. People have talk about aqueductal stenosis. So the aqueduct is the thin tube between the third and fourth ventricle. And some people are born with a small tube that can get smaller. Some people are born with it completely blocked, and that's obstructing the flow out from the ventricles into the system. Now, if you look at the aqueductal stenosis, the interesting thing about it is that if you look here, you can see the ventricle is very large. Here, that's the fourth ventricle, and it's very small because it's not getting fluid coming down into it. If you look at congenital hydrocephalus, most of the time it's not obstructive, it's communicating. We're going to talk about that in a second. But basically the whole fluid system, so here's a normal, and here's the whole fluid system that gets very large. And this is actually an in utero picture of a head. That's the white is the skull, and this black is the fluid. So this is an in utero picture of hydrocephalus. If you notice, this baby that looks just born has a larger than normal size head, and the fontanelle, which is the soft spot up here, and there's another one, would be bulging. This one here obviously is at the other end of the spectrum where it's untreated congenital hydrocephalus, and the head just gets bigger and bigger and bigger, and the sutures never close. That means that the bone never connects within the brain or within the skull, excuse me. All right, so as I said, communicating hydrocephalus is different. In communicating hydrocephalus, all the ventricles are large, just like you can see here. This is the lateral, this is the third, this is the fourth. This is where it comes out, and actually this hole looks huge, and then it goes down and comes around. So communicating hydrocephalus is usually a problem of reabsorption. If you continue to make fluid and you can't reabsorb it, then if the brain can move, it's going to get bigger and bigger and bigger until the point where people start to have symptoms. So in communicating, there's no actual physical blockage, though it's believed that in kids who've had meningitis, that perhaps the granulations and the connection to the vein system is blocked. There are tumors that can produce extra spinal fluid that are located in the choroid plexus, in the ventricles themselves. So that's a tumor problem. And like we said, decreased reabsorption, and some kind of blockage in the vein or after meningitis. And yes, even dogs have hydrocephalus. All right. An entity that has become more recognized now is normal pressure hydrocephalus. It is hydrocephalus in the sense that the ventricles get large, but the way that it presents is very different. It's usually in adults. I put over 50, but they don't have to be over 50. The reason is not completely understood, but there's the thought that as we get older, the brain can't move as much. And so when it can't move as much, it gets stiff. And so the system, rather than pushing the brain out, pushes the fluid into the brain spaces around the ventricles, and it causes what's commonly known as a triad, which are problems walking, urinary incontinence, and dementia. The one that is the most treatable are the walking problems. The dementia can be just from NPH, we call it, but can also be Alzheimer's plus NPH. Now, it's called normal pressure hydrocephalus. And generally, when I do spinal taps, those patients have fluid pressures of 17 or 170, 18, 180. So it's on the high end of normal. I just had somebody a few weeks ago whose opening pressure was 300 or 30. I'm going to give you both. So it can be quite high, but usually it's on the high end of normal. A lot of these patients are treated for dementia, or they're treated for problems with their back, for their walking. But in fact, if you diagnose normal pressure hydrocephalus and treat it, very often 1, 2, and sometimes all 3 of these things can be helped. Now, the way that I treat these patients is I do a lumbar puncture just like with everybody else, and I get an opening pressure, and then I bring them down to a normal pressure. Before I do the first one, I film their walking, and then I film it again after the tap. They don't lie flat, they don't sit down, they get up right away, and I film them again. And you can see an incredible difference. It doesn't last very long because they restart to form the fluid in about 24 to 48 hours, but it's pretty amazing. Okay, I put this in here. It's not really hydrocephalus. However, it is another form of increased pressure in the brain. It's also known as idiopathic intracranial hypertension. It is seen usually in women, usually in the 20 to 40 age group. And if you remember, I told you 0 to 180 is a normal pressure. If you have a head injury and you come into the emergency room with a pressure of 300 to 400, you usually die. But in this group, because the pressure goes up very slowly, the symptoms don't come on very quickly. They come up slowly, and usually the first symptom would be headaches and visual loss, and usually that's peripheral visual loss. And there are a lot of things we know that cause it. Sometimes we have no idea what causes it, but it is treated just like hydrocephalus if medication doesn't work with shunts. All right, so we're going to look at a cut through the brain. We've been looking at the brain from the side, and these are called axial slices. Some of these are CAT scans, some of these are MRI scans, but I'm going to kind of give you an idea of what we look at when we look at a slice. These slices are very close to each other, not exactly, but if you look far over to the left here, so that's the skull over there. And then the dura, which is the covering over the brain, would be around here with the spinal fluid. These are normal size ventricles. If I go over here, I would say the majority of you would say, well, that's hydrocephalus. But I want you to take a good look at the tissue of the brain around these ventricles. You can see that these are called sulci and gyri. You can see that they are getting enlarged. And that's because this brain is the brain of somebody who is older and atrophying. And at the same time, it just makes the ventricles look larger. As opposed to normal pressure hydrocephalus, if you look at the tissue, that looks fairly normal. The ventricles look big. There's a little bit of white up here. And for a reason I don't understand, we see this more with NPH, but this is probably fluid that has gone into the brain tissue around the ventricles. This one over here just shows regular hydrocephalus. And then this one is what I was talking about with pseudotumor. You can barely see the ventricles, and that's probably because the brain starts to take on more and more and more water, so it squeezes the ventricles, and they get very small. Okay. Excuse me for a second. Okay, so how do you diagnose hydrocephalus? I think most of you probably already know that if you go into your doctor and you have symptoms, they're going to send you for a CAT scan or an MRI scan at the beginning. And of course, like I said, with babies, increasing head size and bulging fontanelles. Lumbar punctures you can do for pressure if it's needed, but you have to be really careful, because if you have a lot of pressure up top and you take pressure down from below, you can cause the brain to actually go down the canal, and you can really hurt somebody. So you don't want to do a lumbar puncture if you have very high pressures upstairs. And then one of the things a lot of people have asked me about is, why do you send me to the eye doctor? The sheath around the brain, the spinal cord, also goes around the eye nerves. And so any pressure in the spinal fluid will cause pressure on the back of the eye. Now, these are, you know, when they look at the back of your eye with that little machine, it's an ophthalmoscope, but I don't know. When they look at the back of your eye, what you should see is, this is the retina, so it's the back of the eye. You should see really well-defined edges over here and nice blood vessels. If you look at this one over here, there are no well-defined edges. The blood vessels are all kind of skinny and ugly. And this is called papilledema, and it's a sign of increased pressure in the brain from whatever reason. It doesn't have to be hydrocephalus per se. Okay, so should I take some questions at this point, or should we wait? Okay, okay. So in the 1950s, a gentleman, I think he was from Germany, an engineer, his son had hydrocephalus, and there was no way to treat them at the time. The kids were getting big heads like the one that I showed you before. Excuse me. And his name was Holter, and he made a one-way, I don't know if I can be able to see this.
No.
But no?
Stop share for a second.
Can you put on yours, or?
Yeah, I don't have my video. I could turn my video on. Hold on.
I can see it.
Can you guys see it if I put my video on? There we go.
Okay, so this is it's on there. You can see it because the camera's on me. This is a Holter valve. This is the original valve that was formed for hydrocephalus. It's a one-way valve, and down in this bottom part has a mechanism very similar to some of the valves nowadays. And this was actually the shunt I learned on. They didn't start making all the different fancy schmancy ones until I was in probably second or third year of training. But you can pump it just like other shunts, and it has a one-way valve system. So this end goes to the brain, and then this is a one-way valve, and it goes, well, I'll show you in a second. We'll get there. Okay, so shunts are diversion, where you have a catheter with holes at the end. I don't know if you can see, there's little teeny weeny holes here. And that goes into the ventricular system, usually the right side because that's non-dominant. Some people put them in front. Some people put them behind. And then that gets connected to a valve. And we're going to talk about the different kinds of valves. But again, one-way valve. And up until probably about 94, all the valves were one pressure valve. Now, you can't really have a one pressure valve. You have kind of a scope of pressures depending on whether you're standing, sitting, what you're doing, whether you're coughing. But you had to choose a low pressure, a medium pressure, or a high pressure valve. There weren't any other choices. That gets connected to what we call the distal catheter. That's the catheter that goes either into the abdomen. Now, this is not in the bowel. This is in the space around the bowel. There's already fluid there. And so the space around the fluid, the space around the bowel reabsorbs the fluid from the shunt. This is the orange one over here came out, what did we say, 10 years ago? This
They
is,
can't see it.
what I can do? They can't see it on that?
No, because you're sharing the screen
Oh, okay.
instead of video.
All right, that's okay.
I'll
That's,
show you at the
You,
end.
you can actually see it, just so you know, you can actually see it. If people can adjust their view, you can switch from gallery view to side-by-side speaker, and then you can move your tab over to make your video just as large or larger than the screen you're sharing.
Yeah.
It is viewable.
Katie, I was just going to say, everyone can put it in gallery view. Yes, thank you.
Yeah.
I mean, and speak.
but you can see it on the picture as well. And this tubing is impregnated with antibiotic. And in fact, Primary Children's University of Utah were the first to test if what's called Bactiseal tubing had less number of infections than the tubing before. And the answer is yes. Can you have a problem with the Bactiseal? Well, in all my practice, I've had one person who has had an inflammatory reaction, and I had to go back to the old type of tubing. So it's a nice thing to have. This valve here, so this would be the ventricular side. This is a reservoir where you can actually put a needle through the skin into there and take out fluid from the brain. And then on this one, if you look very closely, and I'll show you some more of them, there's these little metal, funky looking things. This is a magnetic programmable valve. So basically, you can change, rather than having low, medium, or high, you can change the pressure from outside by pulling up the magnet and rotating it so that the resistance to flow changes. Did I have anything here? Oh, yeah. Okay. One of the reasons, so that's the basic shunt. One of the reasons that I called, and his name is Dr. Riva Cambria, and he's in Calgary now, he used to be here, is that there is a lot of work right now on ETVs, which is basically going through, I have a picture later, but going through the skull, going through the lateral ventricle, through the third ventricle, and making a hole at the base of the brain. So if you have a obstructive hydrocephalus and your reabsorption system is working, then if you put an ETV or this hole, then theoretically you would be able to go without a shunt, which is nice because you don't have to worry about infections, you don't have to worry about getting bigger and needing a longer catheter, you don't have to worry about blockages, etc. And when I talked to Dr. Riva Cambria, he had started doing a combination of burning the choroid plexus in the ventricles, because you can put a little scope in now. In the old days, you have to actually open up the brain to do it. So he makes the hole at the bottom, and you have to have a certain anatomy to do it. And then he decreases the amount of choroid plexus to decrease fluid formation and try to keep kids from having shunts. So far, according to, because he does pediatrics, according to him, this works much better for kids over 6 months. There is a good 25% that close off again, and you can go back in, but they never work as well. And it does not work in adults. So sorry, guys. Okay, this is just to, as I told you, on the left-hand side, you can see the under the skin, the ventricular portion. It's on the right-hand side, so they put it on the right-hand side, on the correct side. This is the valve. It's sometimes it's up here, sometimes it's behind the ear. I'm always really careful because people wear glasses and hearing aids. So if you put it too close to the ear, it gets in the way sometimes. And then it goes into the abdominal cavity called the peritoneal cavity. There's also something called the VA shunt. Now, some kids, adults, can't reabsorb fluid through their belly for whatever reason, or they have had so many surgeries in the belly that there's too much scar tissue. You can put a shunt into the heart. Now, the problem with that, they work really well, but the problem with that is that if you get an infection in the shunt, then you get an infection in the brain and in the heart. There also, and I've never done one, but they have for many, many years put them into the gallbladder. Just another place that it can be put. Okay, so we talked about different kinds of shunts, and we talked pretty well about the tubing. There are probably 100 different shunts on the market, easily. Probably 10 companies that make shunts, at least in the US. And there are still shunts that are non-programmable. There are shunts, like I showed you before, that are programmable, and this is a setup to turn the magnet. This one here is the one that we were beta test site in '95, I think, which I still use today, and I really, really like, which this is the programmer for it now. But I find that they're much more reliable, and there are many more settings. If you look over here to the right-hand side, you can see there's 5 settings on this one. Now, for some people, that's perfectly fine. This one here has, I think, 19 settings. And the reason that I like it is that you can make little tweaks. Now, the downside of it is that this one, you can go into an MRI, but it can reset your shunt. So if you have this Codman-Hakim valve, you have to go and have it reset after you have your MRI. And that could be any kind of MRI, not just a brain MRI. This one here is set so that it won't pull up in the MRI. That said, there are new MRIs, the 1.5, and this is going to sound very technical, but there's 1.5 Tesla magnets and there's 5 Tesla magnets. The pictures on a 5 Tesla magnet are much, much better than on a 1.5. However, the shunts are not compatible with the high Tesla magnet. The programmable shunts are not compatible with the high Tesla magnets. And then this is something that Kelly knows very well, which is called an anti-siphon valve. Now, there's really only three different kinds of shunts per se by the way that they work. But what happens often is, and when people stand up, they change the flow because you set the valve at a certain amount. It can't go backwards, can't go forward, but let's say you set it at 12 or 120. Well, when you stand up, gravity pulls the fluid down, and so you're going to drain more than your 120 that it's set at. So what the anti-siphon valves do are, I don't have a picture of one, there's actually one in here, but it's really teeny. It's actually a little chamber that has little balls in it. So when you're lying down, those balls float around. When you stand up, those balls fall to the bottom and don't let the fluid through. Did you know that was how it worked?
Yes.
Yeah. Okay.
You told me.
I told you. I told you. Okay.
When you gave me one.
So we talked about the ETVs, or also called third ventriculostomies, because this is the third ventricle. This is the base of the third ventricle. So you can imagine if you have a blockage here, that you're bypassing this blockage. Now, one big problem, there's a huge artery that runs right here called the basilar artery. And you have to be very, very careful before you do this and know where that basilar artery is, because if you put a scope through the lateral ventricle into the third ventricle, through the floor of the third ventricle, and you get into the basilar artery, there's no way to stop the bleeding. So, yeah. Just so that everybody knows, there is also something called a lumboperitoneal shunt. Years and years and years ago, it was one of the major ways of shunting congenital hydrocephalus and hydrocephalus as people got older. Whoops, lost it. If you look here, here's your spine. So this is the back. There's a catheter that goes up into that same sac. Now, below this area here, there's no spinal cord. That's why we do spinal taps down here. There's just nerve roots and spinal fluid. And so you can put a catheter up in here and it will float with the nerve roots. And then the fluid flows here, and just the same, it goes into the abdomen. Now, here's the big pressure about what we call LP shunts. When you stand up, again, you have gravity. It's pulling the fluid down, and you can overshunt with LP shunts. And if you overshunt, you can give people Chiari malformations. What's a Chiari malformation? The base of the brain actually goes into the spinal canal. Some people have them anyways, but we know that you have to be really careful with LP shunts because they can give people Chiari malformations. So I was very curious, since I don't do pediatrics anymore, about intrauterine shunting. And so I went to my colleague and he said, although they have not done testing to prove whether the baby's IQ is better, and I'm not sure how you would do, I guess you could just compare those who have had shunts after they're born to before. Nobody's really determined whether it changes IQ, but shunting fetuses doesn't work apparently. And they were shunting from the ventricles into the amniotic fluid. But somehow it doesn't seem to work. And as we talked about earlier, the combination of ETV and choroid plexus cauterization post-birth seems to be working in early studies, but as I mentioned earlier, we haven't done it long enough, and we don't know what happens in the long run. This study originated in Africa, where they couldn't get shunts, because when you shunt congenital hydrocephalus after birth, most shunts don't last more than 2 years at a time. And you have to keep changing them, you have to keep changing them. So in Africa, they can't get the shunts. So they started doing work on ETV CPC, and that's where they found that a good percentage of these kids can do fine without the need for a shunt, at least in terms of how long we've been looking at it. So I am going to open up the floor to questions. Oops.
Oh, you're good.
This one? Stop share.
Yep,
Maybe.
maybe.
There we go. No, you're on mute.
Hi. Oh, I'm on mute.
No, I'm talking to Dr. Levitt.
Oh, I'm sorry.
That's okay, no worries. I'm going to put you back on mute, Scott, because I'm going to start with the questions, okay? Dr. Levitt, but you do have to take yourself off of mute. Okay, there. Excellent, thank you. So I do have That was great presentation, a lot of information, but I do have some questions. I think I'll start off with a little bit about shunt systems, the questions for shunt systems, okay?
Sure.
So someone asked, is there an advantage of the atrial shunts versus the peritoneal?
Okay. They both work well. However, as I said, especially in very young children, there is a high incidence of infection. And so you want to keep from going to the heart and causing infection in the heart. But sometimes you don't have a choice. Sometimes you can't use the belly.
Mhm. So is the shunt and the CFS flow affected by atmospheric pressure?
All right, here's a great question. Okay, the shunt itself is not directly affected by atmospheric pressure. In fact, I called a manufacturer and said, I have a patient who wants to go scuba diving. Can he go scuba diving with his shunt? And he said, yes. However, your brain pressure is affected by atmospheric pressure.
Mhm.
So suppose that your shunt drains at, I don't know, 120, and your brain pressure goes up. It'll eventually come down to 120, but you might have a headache until it comes down. But what if it goes below it? Then you have to wait until your spinal fluid reforms to get it back up to that pressure. So the shunt itself does not. It is more position dependent, but our bodies do.
Mhm. That's great because I actually, because I do a lot of answering all the questions that come into HA, and I do get that question a lot. Can I go scuba diving? So yes, I definitely needed to hear
And
that.
people don't go into planes. There's no reason not to go on an airplane.
Yes, that too. I get that question a lot. I just actually answered a question for someone who just said they're in college, but they were doing it online and they wanted to know if they could fly to another state to go to graduate. I'm like, yeah, I think you can. So there's someone who said that their shunt is no longer functioning. Should they be concerned about that?
The answer is maybe. What was the shunt put in for?
Mm-hmm.
Okay. There are people who have shunts that maybe don't need shunts. There are people who are very shunt dependent, like Kelly. If her shunt doesn't work, she gets very sick very quickly. So if the shunt is in, for example, for normal pressure hydrocephalus, what will likely happen is as the pressure and the ventricles change, they'll start to have the symptoms again. If you have congenital hydrocephalus, then you're going to be shunt dependent, and it's very unlikely if your shunt's not working that you won't get sick very quickly.
Now you would even be asking that question because,
Yeah, exactly. So they need to explore a little bit more with their specialists. Absolutely. And how about, you talked a little bit about the Tesla, the difference between 1.5 and 5. Someone wanted to know when you said that they were non-compatible with high Tesla MRIs, do they need to make sure that they have a low Tesla MRI shunt system?
The MRI system is generally 1.5. The 5 Tesla just came out more recently.
Mhm.
Any place you go that has a 5 Tesla magnet will ask you if you have any implants. And if you have implants, they won't put you in that MRI,
Okay.
in the 5.
in the 5, yeah.
Fine. Yeah,
So
exactly.
like I had an MRI last summer and it did reset my shunt, but I had it really close to where Dr. Levitt works, where her office is. And so we did the MRI and then I went directly to her office and she stayed late. Oh, bless your heart, because it like kept getting postponed. And she reset the shunt and then that was that.
one of the things about the newer magnetic shunts is, like I explained, they don't, or they're not supposed to change pressure. The one that Kelly has, it has the multiple different settings, is the older shunt that I happen to like because I think it's very accurate, but that one can be reset by a 1.5 Tesla magnet.
Okay. So let's, a quick question about pressure. You talked about the pressure difference between 0 to 18 or 0 to 180 millimeters. Normal ICP is, someone said normal ICP is what they're getting is from 14 to 18. How does that compare to the 0 to 18 on your slide?
No adult will have an intracranial pressure or ICP of 0. 14 to 18 is in the normal range, but if you have, you can still have symptoms. Some people need their pressure to be 12. They don't do well at 14. And if you have normal pressure hydrocephalus, you may have 14 to 18 in that and be symptomatic and get turned down lower, and you do better.
Okay. And
I
let's,
hope that answers the question.
I hope so too. Does that answer the question for the individual? Oh, it was Felicity. Felicity, are you still on?
Yes, it did. Actually, I was having a major headache. They tested, I had an ICP monitoring, and it was -4 to 4 if I moved around. So a little bit of a headache there.
I would believe it. That's a low pressure headache.
Okay, well, low pressure, let's, someone asked the question, could you please explain low pressure? Like you, so you say high pressure, but some patients say they have low pressure. What does that mean?
Okay. I want you to think about family members who have had spinals for babies and who after the spinals have
Oh, the
had,
epidural? Or the-
well, spinals, epidurals on the, they're kind of like epidurals,
Okay,
but they go into
okay.
the sac. And after that, they leak spinal fluid. Well, their body, and I'm not talking about hydrocephalic patients, I'm talking about regular patients. Their body's used to, let's say, 15. Well, you had a needle, the hole hasn't closed up, and your pressure's down at 8. And they have horrendous low pressure headaches. So it's actually a variable of pressures, and everybody has different pressures that they do well at. And in people who have had spinals or a spinal tap and their pressure is low, we put them flat. Why? Because when you sit up, you're going to drain more. So we put them flat, we give them lots of fluids, and there's something called a blood patch you can do for that, where you take blood out of your arm and put it where the puncture was done to close the hole. It'll eventually close itself.
Mhm.
And then with the shunts, a low pressure is, it's draining too much, or it's,
Well, it's draining more than the patient needs.
Okay. Can you explain slit ventricle syndrome?
Absolutely. Okay. So if you remember back to the picture where I had all those cuts, the one far over to the right had these teeny weeny ventricles.
Mhm.
And there are some patients, and they tend to be pediatric patients usually, that are either one, overdrained. And so if you overdrain, then your ventricles are going to get very, very small. And you can have headaches from that. But there's also people who have shunts that are functioning that have slit ventricles because the shunt's not low enough. So it drains, but the ventricles aren't getting bigger. The fluid's going into the brain around it. And you actually have to put a second shunt in on some of those people.
Mhm.
If you go back 20 years, we used to take out the bone on the side of the head to relieve the pressure on the brain. But generally now with the programmable shunts, it's much easier to regulate,
Mhm.
and it's more often low pressure than it is very high pressure.
Mhm. Okay. I always, every time someone calls in, they say they have slit ventricle syndrome, they'll be like, I am the most complicated case. So I hear that more so, like complicated cases with slit ventricle syndrome than anybody else that I've spoken to. So can we talk about symptoms, signs and symptoms? So someone wants to know when they do sit-ups or they lay down in the dentist chair, just different positions, they get a little dizzy in the head. Could that be because of sudden changes in CFS in their brain?
It is probably because of differences in the pressure between lying down and sitting up. Even people who don't have hydrocephalus, if you get up too fast, what happens? You get dizzy. So your blood, you need to get enough blood to your brain. And so when you, somebody just said, my doc said I am a complex hydro. When you get up, your body has to pump that blood harder to get it up to your head. But in somebody who's shunted, if you think about it, when you change positions, especially if you don't have an anti-siphon, you're going to drain more or less. And so you may feel dizzy just from that.
Okay. So if someone is experiencing something like, especially with NPH, when they have urinary incontinence, or if they have, softened stool, do you think that's something that has to do with the shunt setting, those symptoms? Is it too
Often,
much, too
yeah.
open, or is it maybe too open or too close?
Okay. Softened stool has nothing to do with shunts.
Okay.
So you can take that off the record. One of the things about normal pressure hydrocephalus is that I always get a initial pressure measurement, and I set the shunt at that pressure, and then I slowly dial it down over weeks. Why? Because if you think about the brain as being a little bit more solid, it's going to start to compress, and then there's blood vessels between the brain and the covering over the brain, and you can get bleeding. And they're called hematomas, subdural hematomas. So what I do is I start pretty much at the pressure that they had at the beginning, and I tell them they're not going to get better right away. And then I start turning it down little by little to let the brain adapt to the pressure. At one point, you'll likely see improvement in the walking, maybe in the urinary incontinence. Like I said, the dementia is the hardest to get at. The other thing that I see with NPH patients is that generally around, and I warn them, around 2 years after they've been shunted and they're at a pressure that they're doing well, they start to get new symptoms. The same symptoms come back. And I think that's because the brain is older and it's getting more stiff. And so I turn the shunts down, usually by 2 on the ones that I'm using. And often, maybe they'll need another one 5-10 years later, but often that's all they need.
Okay. So while we're on the topic of NPH, one of the slides you showed the difference between the ventricles, especially with NPH in the brain. Did you say sulci? That's the word you use, I think. Is that
between the atrophic brain, the one that has atrophy, and the one that has NPH?
Yes. So how do you determine outside of that scan that person is a candidate for shunt surgery?
What I usually do, if somebody looks like they have atrophy and they have dementia and maybe urinary incontinence, I'll tell them, I don't think a shunt's going to work for you, but I'll be happy to do a spinal tap and see if you feel better, if things get better for a short period of time. I would say 90% of the time I'm pretty accurate as to who has NPH and who has atrophy.
Okay. So do you have any like research on what's the success rate for individuals with NPH and shunting? How long they usually, I guess, recover after shunt surgery? Do they, just live a successful, what's the prognosis? That's what basically this question is asking.
Okay. I would say that if in my patients who've had a spinal tap and do well with their walking, if they have mostly walking problems, I would say 75 to 80% do really well with shunts. Now, very, very important. For a reason I don't completely understand, shunts last longer in those patients than they do in the young population.
Oh.
So I often don't see them back. Now, you still can have dementia. You still can have, other problems, black back problems, urinary problems due to other things that the shunt's not going to fix. So in the older population, I guess I'm trying to think of the longest follow-up, but usually people don't follow up because they're doing well, I think.
Okay. What if someone says that they can ride a bike and they can swim, they have no problem doing that, but when it comes to walking after being shunted with, being diagnosed with NPH, they're still having difficulty, although they can ride the bike and swim.
Okay. So there's something called magnetic gait that is very similar to what you see in Parkinson's disease. It's a gait where you can't get your feet to move. It gets stuck to the ground. So the possibilities are, one, the shunt's not low enough. It's not set low enough for this patient. Or two, there is some other neurologic problem that's causing the walking problem. I said problem twice, but.
How would you diagnose that? Would you do an LP and see if they felt better?
I just turned it down and see if they felt better. There's
Oh,
no reason to do an
that's
LP.
easy. Yeah, do that.
Let me see. So I'm missing some questions here. Wow. Okay, so trying to read, okay, can NPH cause numbness in the feet?
No.
Okay. And let's see. What is the normal pressure for older adults? Is it still 14 to 8?
Everybody is different. If somebody is normal, completely normal, has no signs of hydrocephalus, they can be 18 or they can be 10.
Okay. Okay, now let's talk about malfunctions and complications.
Ah, yes.
So how would someone know if their shunt stops working or if there is a malfunction?
Right. Firstly, everybody who's been shunted since childhood knows when the shunt's not working. They tell us. I can tell you that 100%. The people that are shunted later may have re-onset of their symptoms. If they have NPH, it's possible their shunt just needs to be turned down.
Mm-hmm.
You can, in obstructive and communicating hydrocephalus, look at the ventricular size, but as we get older, that doesn't always change as much. And for NPH, there's no point in doing that because the ventricle size doesn't change very much anyways.
Okay. So we usually, as we age anyway, doesn't our ventricles enlarge, right? No matter what.
If you have atrophy.
If you have atrophy, okay, all right. So how do you determine that a shunt is clogged?
Well, first they tell me. There's a few different ways you can do it. You can do a scan in the patients where a scan can be helpful. You can actually put dye through that reservoir I showed you into the shunt system, and it should flow down over a certain amount of time, and you watch it under X-ray. Doing a spinal tap, I don't like doing them if somebody has very large ventricles for the reasons that I explained before. There was a product on the market that didn't work, but was really a cool idea where you ice the shunt up here and you measure the difference in temperature further down. And theoretically, if it got colder, then your shunt was open, but it didn't work. It didn't work. It was a nice idea. So putting dye in a shunt is called a shuntogram. You also want to do X-rays and make sure your shunt's not disconnected, because the pieces are tied together. And so if you have a disconnection, then your shunt's not going to work properly.
Okay.
But inevitably, if the symptoms keep getting worse and worse, and
Then-
turning it down doesn't help, you would go in. And look
Exactly.
at the shunt itself.
This is, if in certain people, I would just go in and do it. You know, you do a CAT scan and say, we're going in, we're going to see which part. And if you think about it, the part that's going to break the most often is the valve, because it's the most mechanical. In little kids, the ventricular catheter is also a big problem because the choroid plexus tends to grow into it. And so it doesn't work properly sometimes. So there are kind of different ways to figure it out. But if somebody comes in with huge ventricles and sick, they go to the operating room immediately.
Okay. Well, I like this. This is a very, very straightforward question. Sheena, are you still on?
Yes, I am.
Okay,
Yes.
would you like to ask your question?
Oh, my question is, it's been 7 months since I had my shunt surgery. And so what would Dr. Levitt recommend, to see a neurologist or a neurosurgeon?
What for?
Just follow up. I did not have a follow-up.
If your shunt is working fine and you're not symptomatic, you don't need to see anybody.
Okay.
Don't spend your money.
But how to know if it is working? I mean, if I don't have the symptom, then it's
If you have no
working fine.
symptoms, it's working, or you don't need it.
Yeah. My memory is the one that is not working. So that's the problem with me.
If it's your memory, I would see a neurologist.
Okay.
But there's more to your story, so I'm not going to say one way or the other.
Okay. Thank you. Thank you very much.
You're welcome.
Thank you, Sheena.
Thank you.
So let's talk about research. Why are shunts not saved? Well, I'm not aware of this. I thought some shunts were saved, but why are shunts not saved for research to study why they fail? Without saving these shunts, how can researchers move forward in knowing, the mechanical or medical reasons for the shunts that fail?
Those things have already all been studied. And so if you think how many shunts have been implanted and explanted in the US over lifetime or per year, it wouldn't make any difference. It's either something mechanical within the valve and they break, or something stuck in it. So choroid plexus gets stuck in it. It gets blocked from an infection. So there's really no reason to hold on to them other than to show your patients what they look like.
Yes. I know there is, I'm trying to remember the researcher name, although it's not necessarily, determining why the shunts fail. It's helping to figure out blockage, but I can't, Dr. Carolyn Harris, she's collecting shunts and they're like studying different ways to prevent blockage and things like that. So
I wish her a lot of luck. Shunts have been around for a long time, and I think that many things have been tried, but I wish her luck. I hope it works.
So speaking of talking about progress, what advances have you seen in the shunt technology in the past decade or so?
Well, number one are the MRI compatible shunts. As I said, I don't like them as much because you can't change to as many different pressures. They're much easier to reset. You just need this little magnet thing that you stick on somebody's head and you just turn it. So what it does is it lifts up the magnet and you turn it, it turns the magnet, and then it lets the magnet back down. The biggest problem, I think, is shunts are going to fail, and it would be nice to find a way that people didn't need them.
Yeah. Yes. No more brain surgeries. Absolutely.
Hashtag.
And so people are wondering, are you accepting new patients?
Yes.
They love you. They love the presentation. So what
Thank you. I appreciate that.
What words of wisdom would you give everybody here? Many of everybody on here are adults. Well, I think everybody on here are adults with hydrocephalus. So what's some words of wisdom you would give them for managing their care?
Make sure that you talk to your doctor, and I know neurosurgeons aren't always easy to talk to, and a lot of neurosurgeons have PAs or nurse practitioners that do a lot of the after work. Actually, I'm going to let Kelly answer that question because that's how she became my patient. So what kind of things would you have done differently?
Oh, found Jodie first before I went through 4 other neurosurgeons who had fun with my brain. I think the biggest thing is be your own advocate, or have someone side by side with you to be your advocate, because you know your body. There are times where with previous neurosurgeons, I'd say, this is going on, fix it. Like, I know I need this. Can you do this for me? And they try something else, and it was very frustrating. So I just kept pushing for answers, and I found Dr. Levitt. And the first time I met with her, she sat down, saw everything, looked at all the scans, all the documents, listened to the story, and she just wanted to solve it. So she
I like puzzles.
Anytime there's a problem, Jodie's like, ooh, what can we do with that? She saw her trampoline in the backyard. She's like, oh, what can we do about that concrete barrier? Let's think of something else we could use. So I'm like, oh, Jodie found a problem that needs a solution. But be your own advocate, and just when there are questions, find the answers, put together a medical team. I go to a neurologist for pain management. I still have some types of headaches. Is it caused by the shunt? We don't think so, because it's working. We know it's working. So I have a neurologist. I have a physical therapist that helps me with neck muscle issues. And I have one who works on tissue. So like any scar tissue, she helps work that out so the shunt tubing can move comfortably. I have an eye doctor, a regular eye doctor, and a neuro-ophthalmologist. So you have put together a healthcare team that can answer all those questions. The neurosurgeon can definitely refer you, like maybe you should go see this person, but takes some time to put together that team. Ask other people for advice. I know a lot of our adults with hydrocephalus group are in California. Let's start talking to each other. Find who do you go to? Who do you like? But yeah.
And understand that my belief is that as adults get older, that they're going to be less tolerant of differences in pressure.
Mhm.
And so Kelly and I worked for a long time trying to figure out what was shunt and what wasn't shunt.
Mhm.
And it's a process, but I honestly think that as we get older, just like in normal pressure hydrocephalus, that adults don't tolerate the changes in their intracranial pressure as well as children do.
So like they were talking about atmospheric pressure, barometric pressure. I have on like the, what is that called? Not the home screen, but the lock screen of my phone. I have battery life and I have barometric pressure, current pressure, because I noticed that as it changes, my internal weather system tells me what's going on, or I'll get a headache, and it's that kind of a headache where I'm like, oh, is there a storm rolling in? And sure enough, there is. So
Our bodies tell us a lot of things. It's like grandma used to tell me, my knee, my arthritis gets so bad when it's going to rain. I can tell when it's going to rain. It's exactly the same thing. Our body tells us that things are changing.
Mhm.
yeah.
Yeah, and I do, Kelly, I agree 100%. Make, forming a team approach is the best approach. That's what I always tell everybody, please. Make sure you have
One
it.
of the,
Mhm.
I'm sorry, one of the things that's people get really annoyed about is when their doctor doesn't call them back. But often what will happen is with little changes, they'll call and they'll call and they'll call and they'll call and they'll call, and because they don't have an answer. And so probably better to, make a visit, go in, see what your doc has to say, and see if something else maybe is increasing your headaches or increasing the problems that you're having at that point in time. Because you'll have a nurse practitioner call you back and say, we don't know what's wrong. Sorry.
Exactly. Thank you so much, Dr. Levitt, for joining us. I don't want to take all of your time. I do know that you have to head home. So thank you, Kelly, for organizing this and hosting and bringing Dr. Jodie to our community network. Thank you, everyone, for joining and being patient and submitting your questions. We do appreciate it. I hope everyone have a wonderful night and a happy Mother's Day weekend to those who have children. So
Thank you, everyone, for coming. I really appreciate it. And I hope that I helped you understand. That's what I love to do.
when we,
Thank you. June 4th for our next Zoom meeting.
yes. Good night, everyone.
Thank you so
Hey,
much.
y'all.
You're
Be
welcome.
well. Take
Bye.
care.
Yes.